lead nurse covering our 2 urban methadone clinics in Springfield and in Holyoke. And they're going to talk about what we did at our 4 OTPs in Western Mass when the new SAMHSA take-home guidance came out, what's known as the guidance, which removed the 8-point criteria down to 5-point criteria. And we're just going to talk through how it looked from a clinical and a nursing standpoint to put these changes into effect. So I'm not moderating, I'm sitting down, these 2 are in charge. Oh, no, you start talking. I've got to share the slides, but if you don't mind starting to talk, is that okay? Okay.
So I'm Calla Harrington, and when we got the new SAMHSA guidance, there was a lot of reactions in our clinics, right? Various reactions. And as a social worker and a therapist, I'm there for the feelings, but I use the words reaction because not everyone is. Oh, thank you. So just to give the language exactly, the SAMHSA guidance says, that you should consider, oh, thank you. You should consider starting people on take-homes relatively quickly and the numbers. And then they gave the criteria to think about were less about toxicology specifically, and more about the comprehensive patient stability, right?
So when we got the new guidelines, we started off by taking off THC from our toxicology reports, and we started to focus on more substances that were harmful when taken with methadone. We focused on our benzos, our alcohol use, and other opiates, and cocaine. We started to actually look at the levels that came back from our swabs and our fentanyls. And we started to focus on, are the fentanyl levels decreasing in the patient's toxicology reports? Then we started to focus on, is it a good idea for anyone to come into the clinic every single day and dose? These people are mothers, they take care of other family members, they work, and can, like anyone in this room, literally go somewhere every single day and dose. So we started handing out bottles, and we focused on, like, is the patient misusing the bottles, or are they taking illicit substances like benzos? And we kind of picked each patient individually and said, okay, are they the right patient to take home bottles safely? So in Springfield, in our Springfield location, the blue column shows the take-home bottle criteria before SAMHSA rolled out the new guidelines. The red column shows how many bottles we rolled out after the guidelines. There were people that were dosing 2 to 3 times a week. We literally doubled them up to weekly or 13 or 27 take-home bottles. And it initially doubled the amount of bottles in the end. So people were getting like 27 bottles coming in once a month. And then it just basically increased our patient satisfaction rate. In orange, in our rural areas, we did the same thing. We literally took the patients that were coming in daily or 2 times a week, and we increased them to 13 bottles, 27 bottles, and they literally doubled by the end of September of 2023.
So with big changes, including that toxicology is not everything. So it used to be, we considered a patient to be stable and capable of having 2 weeks or more of take-homes if their toxicology was less than 1 for fentanyl on an oral swab. And we started to re-examine that and that brought up a lot of feelings and a lot of reactions. Whenever there are big changes, I think it's helpful to look at your code of ethics. For me, that's the NASW, as well as the American Public Health Association. The ones that came up that were relevant to me was promoting well-being of clients as well as the greater community safety. And then respect and promote the rights of clients to self-determination and assist clients in their efforts to identify and clarify their goals. Social workers must also take action against oppression, racism, discrimination, and inequities, and acknowledge personal privileges. And again, methadone wasn't set up for most of our clients, right? It wasn't set up for them to succeed very easily historically. And so acknowledging that the requirements for daily dosing really impede people's goals, their self-determination to have stable employment. It really reduces the number of employers that they can seek. It can impact their families and family involvement, as well as community integration. And then within this Code of Public Health Ethics, professionalism and trust. So this, it's a beautiful document. If you haven't read it, they talk about how public health professionals earn public trust by using evidence-based practices. And when we don't have the evidence, we need to seek it out. We need to seek the data. And then if that data tells us what we're doing can be better, could be changed, we have to do it. That's how we earn public trust. And it must address health justice and health inequities. And when we think about access to life-saving medication, of course, that's a human right, civil liberties come up. So here are some of the reactions that we experienced among various staff. Anger. So the sense that feeling the clients are getting away with bad behavior. So this would be, for example, a client who has 2 weeks or more of take-homes, very stable in their work life, not presenting concerningly at the window, no issues with their bottles, steadily employed, and then we get their oral swab results 10 business days later that says they're metabolites for cocaine, right? So that overall picture does not support that one screen is not enough to say that's an active substance use disorder. And it's also not enough to say that that patient is inherently unstable. In fact, if you think about, if we're honest with ourselves, any time that somebody used cocaine or an illicit substance, if any time that somebody used an illicit substance in life, we would have such dysregulation in our society, right? You think about people with power often use substances with zero repercussions. You think about all these other folks. We wouldn't know unless we were over monitoring, right? That's the kind of patients that we're talking about. So what did we do with that reaction, right? Our focus is on changing behavior and pulling somebody off of all their take-homes because they used cocaine like 2 weeks ago and nothing else has happened is relying on a model of behavioral management that's limited, right? If you're relying so much on operant conditioning and punishment, and you're not taking into effect that helping people meet their basic needs also changes behavior, right? And if we pull away somebody's access to stable employment because they had a positive for cocaine, we are not creating more stability in that patient's life. Some other reactions were fear that something bad will happen on our watch, right? So this fear of liability. And what we did with that is we re-examined what kind of accountability do patients have with other medications. Like I have friends who are not the best with their even like heart meds, you know, I'm like, you should do better with that, but also we're not regulating them in the same way. And documenting our reasons for why we think this person should have take-homes. So when we have that documentation to say, there is no other evidence that this patient is unstable or unsafe other than this metabolite of cocaine, we have covered, you know, we've stated why we think this patient is safe with their bottles. We also use callbacks, right? So it's a great tool, random callbacks, bottle counts, we use them. So if you have concerns that somebody might be diverting their medication for another illicit substance, do a callback, right? Ensuring take-homes, orientation and safety and education prior to bottles. So every patient has to at least once a year do the orientation to methadone and take-home bottle safety. And in that, we discuss the importance of taking your medications as prescribed and all of that stuff. Like, we cover the basics so the patients know what is expected of them. Slippery slope and a sense of loss of control. So some clinicians even were feeling, if I can't pull somebody back, or not can't, but if it's not inherently expected that I will pull somebody back, they're not going to respect me in the same way, or I won't have the same kind of power in our relationship. And to that, I say, maybe that wasn't an appropriate amount of power you had before. You know, and just thinking about our values to really push that discomfort. Some other reactions, we had a sense of relief. So, you know, if you've known helping professionals, sometimes folks are conflict avoidant, right? And so sometimes people are like, oh, thank God I have less fights to have with the clients, either at the window or in dosing. And we said, yes, and let's still make sure we're not setting patients up for failure, right? Like, not just throwing it out there for anybody, regardless of their clinical presentation. So making sure we're setting up folks for their best success. Allowing for more honesty and assessment with clinicians and nurses. So I did get a lot of folks who are very relieved. They're like, oh, finally, now it's one less reason that somebody has to hide whatever they're doing. Like, they can just tell me, hey, I had a slip. And we can actually talk about how to prevent that, what it meant for them, and move forward without it being a big burden. Some other reactions are confusion. So how do nurses know if a positive screen means reduced take-homes or not? Like, we loved the black and white. Like, if it was positive, goodbye bottles. This is not clear cut, but we have so many options and there's a team, and we don't have to make a decision right in that moment, right? We can limit the number of take-homes that person can have until a comprehensive assessment, right, with a clinician to see what is this patient stable or not. And we can allow nurses to utilize their best judgment at the window. So it's not forcing somebody to say anything. It's allowing for an option of dialogue and for alternatives to be considered. And won't clients be confused? We heard a lot of staff be really concerned about clients' reactions. Like, say, I know so-and-so used because I used with them and they got their bottles, what about me? And to that, we talk about how treatment is individualized, right? We don't say that all people with depression need X number of treatments and this certain type of therapy. And so why should it be the same? Like, we don't have to explain someone else's treatment plan, but just say treatment is individualized. So here are some of the patients' responses when we talk to them. What does that mean for you? And these are some patients who shared that decision sharing, making methadone more accessible saves lives, reduces demand for street methadone, and it also supports sustaining recovery capital, such as stable employment. This is direct quote. I would not be here if I wasn't able to get take-homes. I couldn't afford to not work or be late to a work site every day. Take-home methadone, works I haven't used in months. I'm a business owner, and if I hadn't had take-homes, I wouldn't be here at all. People aren't selling it like they thought we would at my last clinic. When my kid died and I went off the deep end and I went to the streets to buy what I had to buy, there wasn't liquid methadone. Why bother when they make it easy enough to be a patient? You can get in, you can get your own medication and not have to worry about it or pay. And then another client. He recognized decisions based on a single screen misses progress and may not represent stability overall. It's not always black and white. I took a hit off somebody's bowl. I don't think pot is an issue for me. And they had used other substances, I guess. So here the screen says black and white, but I have been intentional about not using things. I also think if somebody's got some crack now and then, it's different. It's got nothing to do with treatment here, really. Maybe a little rationalization there. If they're still using fentanyl constantly, then I don't see the point personally of take homes. A slip I can see continuing with take homes. I'm using the clinic to be with my kids and better my life, and it's working. So it's a whole thing. So these are some examples of the meaningful impact of not having a single toxicology determine whether or not somebody is able to have a certain number of take homes. And this also comes back to stability overall and recognizing that not everyone has the same access to different levels of stability. I believe if we direct clients to take the next steps in their recovery or their lives without acknowledging that the next step requires more resources, and we make it harder to stay on the rung they are on by continuing daily dosing despite the cost of daily dosing outweighing the risks of take homes, we are part of the reason patients fall off treatment. And falling off treatment often means losing quality of life, if not their life altogether.
Thanks, you too. So questions if people have them, or if you want to stand up and say, yeah, we made changes in our policies as well, and this is how it went for us. I'd love to hear that too. I was in New York for the Liberate Methadone conference last night, and I actually looked at the numbers for the Greenwich House. They also have 1,000 patients in the Bronx, and they had something like, and I'm now making up numbers, but I think 30 or 40% of their people were on 27 take homes. Like, I looked at my numbers and thought, I'm doing not that job right now, but you can see it. We didn't go crazy. We didn't give half the building 27 bottles. Calla says this all the time. 27 bottles is a lot of responsibility, quite honestly. It's a lot. You screw that up, you're kind of screwed. And for many of our patients, they'll say, like, I'm good at 6. Like, coming in here once a week is good enough. That I can manage 6. It's not going to get lost or stolen as much. Like, the chaos of my life holding on to 27 is more than I can manage. So I do think that more of us, and we ran these numbers across all of our programs, and the numbers all look the same. We basically push people out to once a week, and we push more people out to 13, and a group of people got to 27. But I'm just curious what other people have done with the new guidance. Have you made changes? Are you less reliant on toxicology defining what happens to your patients? If you have questions for either of these two, come on up to the mic. If you don't mind, do you mind? Can you get to the mic? Okay.
Hi, my name is Rosemary Spada. I work with Fuller Hospital in Attleboro. I was just wondering, what do you do about lost doses or stolen doses? How do you handle that?
Jason, you got that one?
So initially, of course, it's individualized per patient. We kind of take an account of their story of what happened. We have them bring a police report in case, you know, if it actually was stolen by another person or if their boyfriend threw it out or something like that. Then we'll go to the medical director, Dr. Pote, and we'll present what the patient presented to us and just literally just determine whether that patient should either be redosed or should we just dose them daily at the window? Are they capable of getting take-home bottles again? And things like that.
We also are starting to, if there's like a pattern of stolen bottles, we look at that, right? We use in our MethaSoft, which is our methadone distributing system, we use these flags that communicate across reception, counseling, and nursing. And so they can leave a flag in for a while saying, at this date, so-and-so is stolen bottles, right? And so then we start to have some data and all parties are aware of how many times somebody's having stolen bottles.
Hi, thanks, guys. I just wanted to say, we recently had somebody who had their methadone stolen. And this patient went to 2 different police stations and they refused to take the police report, which was really painful. He did all the right things. And we were asking, and it was just, and it made me really upset because he did everything we asked him to do and he still couldn't produce what the medical director was looking for. So I think context and the story and the patient's history and who they are, and also the relationship they have with their counselor and their team is of paramount importance. And moving forward, I wouldn't, if a police precinct is unwilling to take a report, we're not going to make them suffer the consequences, because his story was believable. And anyway, I just wanted to volunteer. So I think it's okay to ask, but there are police stations that will not, we don't do that. That's not our job. Is we don't do medication. It's, and he was pained. Anyway, so thank you.
Yeah, thank you. Yeah, we have also had, I have one client who has said that the police officer refused to do a police report for them. There was enough other stuff going on with that specific person that we were like, okay, I'm not comfortable giving you take homes right now. But we'll discuss it in another 7 days. So it's also not a forever, right? It's individualized, and it's not one confusing or concerning incident means you lose everything forever.
I think that brought up a question that I've always sort of pontificated on, but what is the point of a police report? They don't investigate it when they take them anyway. So why, does it just make us feel better that we made them do that?
Documentation. Hi, I just had a question about the talk screen for take homes. I think it's great that they don't necessarily lose their take homes because they may have had a relapse. We talk about it all the time. Relapse is part of recovery. And when they come in, we provide them with so much support and they're able to be honest. And we help them through treatment. And then when they get to be so stable and they have a slip up, they have nowhere to go to talk about it. And we can't help them through it because we're going to take their take homes and they're going to lose their stability. So is that part of the new regs that if they have a positive talk screen, we don't have to take their take homes from them?
The language, I think, says active substance use disorder. And when use does not necessarily, it's about the overall picture. What does the client's employment, health, et cetera, look like? And did that change because of the use, right? And also one use a couple weeks ago of cocaine does not, unless you did some really rash illegal behaviors while you were high on cocaine, is not really going to impact. It doesn't meet the criteria for active substance use disorder.
And so the new language, you could even maybe utilize decreasing the amount of take homes they have rather than eliminating. them
Absolutely.
altogether.
Again, the 8-point criteria said any positive toxicology. It didn't even define what positive toxicology was, and included marijuana. So it was really hard to actually give people take-home bottles with the 8-point criteria. But again, as Calla describes, it's really, has this person really entered into or re-entered back into an active use disorder that you need to be worried about? So yeah, in those circumstances, you would have to then start to pull back bottles. But again, one-off use. I mean, you guys aren't going to like me for saying this, but I'm going to say it anyway. A lot of people on methadone continue to use fentanyl, but they use it in a very limited way, right? They use a couple bags at night. They use a couple bags a few times a week. Is that actually a use disorder? Fentanyl's not bad for it's bad for your health. I think we'll all say that, but they actually have really controlled use. It's not creating chaos in their lives. Their life is no longer blowing up. They're 98% better. When we write our notes for annuals, we write % reduction in use. Do you know how often I write 100%? Not very often. Instead, I say, I look at my note. When you walked in here, you were using 10 times a day and you were using 4 grams a day. And now you tell me, and based on your drug screen, I can maybe confirm that, but more importantly, you tell me you use now once or twice a week. Based on the math of that, that's a 95 to 98% reduction in use. Praise be. right? Amazing. If I got a 98% improvement in any other chronic health condition that I've taken care of as a family doctor, I'd be over the moon, right? Instead, I get no improvement on many things. So that for me is somebody who no longer has loss of control. I think it's extraordinary. We've been fighting with Quest, actually. I mean, I'm not promoting them. They happen to be the people we run our GCS mouse swabs through. They're testing down to the 0.02 or 0.01 nanograms of fentanyl. And we're like, stop. Too much information, stop it. And I've been fighting with their head of toxicology nationwide, and they say, but we're doing this important thing everybody needs to know. I said, that's fine. If you want to test for other reasons, for other forensic reasons, for other people, methadone clinics don't need that data. In the world of lipophilic fentanyl, somebody using 42 days ago is not relevant to the care they need now. So let's do a different cutoff. Give me any other cutoff. The OTPs in this room could decide a cutoff and say, we in Massachusetts will not be using Quest unless you change your cutoff for us. It's hard to do that, but I would love to do that. Thank you. Todd, do you have, oh, you're here? Yeah.
I have one question. I might as well ask it since I have you guys here. My name is Lynn Cruzado. I am nurse manager for Baco's ATSs. Andrew House, most of you probably heard about us. It's about the take homes. We had this situation a couple weeks ago. A client comes in on 95 milligrams of methadone. During our search of their property, we find 2 empty take home bottles dated for the, it was a Friday, so Saturday, Sunday, empty. Client very under the influence, looks very sedated, so we're worried that they either, took them. When we interview the client, they say, no, I sold them to get something else to use. We call the clinic, we let them know, the client came in today, he was dosed that day, that was verified with the clinic, and the 2 empties. So we're like, what do we do? Are you guys gonna, what is their response? The nurse laughed. And we just monitored the client. The NP decided to do like a different thing with their methadone maintenance, gave her a lower dose in the morning, split dosed them that next day to kind of make sure they were safe. But what happens when somebody comes in and they have a full bottle of methadone, which he was supposed to be taking that weekend, but we're not going to give them that take-home bottle the next day because we do our own methadone dosing. And we call the clinic. Are we allowed to dispose of it with the clinic's instruction?
So if I had that happen to me, I feel like it depends on like some places that you go to, they actually dose the patient out of it. But if you call us and you say, hey, this patient came here with a full bottle of methadone, can I dispose of it? I'm fine with it. We normally would document that, whatever facility disposed of the methadone. And then when the patient comes back to us, we won't penalize them for having an empty bottle.
Okay, because we just don't want to send people out with extra methadone dosing, so
Because some
we
people
feel it's
will
our
go home
responsibility to,
and take that one too. So.
okay, so
that's-
communication.
Yeah, communication. You describe a very concerning story when somebody either diverted or overtook their methadone. That's not acceptable. Like, we may seem like, oh, we're throwing out the bottles out into the wind. We're not. You have to demonstrate to us that you can manage the bottles. So let's take 2 questions and then we're probably going to close it out. Todd, and then over here.
I'll be brief. Todd Kerensky, South Shore Health. First of all, thank you very, very much for this presentation. These are comments really, but we need to empower clinicians and nurses within OTPs. Okay, that is really important. So MASAM needs to help support that statewide. Secondly, as it pertains to the regulation around take homes, from my perspective only, this is crazy. What the regulation needs to say is that it's up to the OTP to decide who qualifies for take homes and who does not. Putting it in the regulation and this arbitrary decision about when a lapse turns into, again, use disorder in the context of someone with a use disorder is bananas. It's bananas. It is up to the OTP to decide. And if we can't get the regulations changed, it's a problem from my perspective. Thank you.
Massachusetts has said that they've often thought, DIA's often thought about just exempting the entire state from 42 CFR and doing what we want to do, but we're not there yet, but still her plan.
I'm David Gasprin from Dynamic Care Health. And just so you know, we market an app for contingency management. And I want to bring this up because we keep talking about punishment, punishment, punishment for slips, lapse, relapse. It's a reward disorder. In Rhode Island, the methadone programs are now funded statewide to provide rewards for people to work on their health for harm reduction purposes. Now, if people can achieve abstinence, they can get rewards for that. And that's work. And it takes time, and that can take months. It can take more than half a year for people to earn the rewards to get there. But before they even think about that, they can be rewarded for attendance. So you boost attendance rates. They can be rewarded for doing cognitive behavioral therapy modules in their phone at the moment of need, nighttime, weekends. They can do remote saliva drug tests so that their take homes can be monitored for taking the medication. You can even have video selfies of the patient taking their methadone so that you know they're taking it. It's them at the right time, the right dose, the right way. And so there's funding for this. Other systems, centers of excellence across Pittsburgh and Allegheny County and Pennsylvania are doing this. So we should be treating a reward disorder with both sanctions for protections of patients, but rewards for the brain disease. And if we can advance methadone treatment with this, we already do it with take homes. That's a reward, but it's a sort of a course reward. So it's not the only one we should be thinking about.
Thank you,
Thank
Dana.
you.
You guys, today was really intense, all methadone all day. Good. Tomorrow is not that. So firstly, if anybody wants our take-home bottle policy, because you don't want to have to recreate the wheel, you're going to email Laura Masika. She told me she'd send it out to anybody. So take a picture of that screen. Secondly, please make sure you get your CME credits the way I told you to earlier. We'll post it again tomorrow. Tomorrow is about psychedelics and alcohol and hospital-based treatment of people who struggle with opiate use disorder and a whole bunch of other things. It's a full, amazing day. There's going to be an award ceremony. It's going to be a great day here. It starts freaking early at the morning. Todd is at the podium at 7:55. Don't be late. Thank you, everyone, for being here.